Alright, now we're diving into the chapter-specific guidelines, starting with Chapter 1, Certain Infectious and Parasitic Diseases, and specifically, HIV coding. This chapter can feel intimidating at first, but once you understand the logic behind the guidelines, everything starts to click. Before we get started, a quick but important disclosure. This presentation is intended for educational purposes only. It does not constitute legal, compliance, or billing advice. Always refer to official coding guidelines, organizational policies, and regulatory requirements when making coding decisions. In HIV coding, everything begins with one core rule. We only code confirmed cases. And the good news is, confirmation doesn't require lab results. If the provider documents that the patient is HIV positive or has an HIV-related illness, that's enough for coding purposes. Once HIV is confirmed, our next job is to figure out whether the patient is symptomatic or asymptomatic. This single decision determines whether we assign B20 or Z21. Think of it like two paths. If the provider documents AIDS, HIV disease, or any HIV-related illness, that's B20. If the patient is HIV positive with no symptoms, that's Z21. When a patient is admitted for an HIV-related condition, B20 becomes the principal diagnosis, followed by codes for the specific HIV-related conditions. There is one important exception: hemolytic uremic syndrome associated with HIV. In that case, D59.31 takes priority, and B20 becomes secondary. If a patient already has HIV disease and they're admitted for something unrelated, like a fracture or appendicitis, the unrelated condition is the principal diagnosis. B20 still gets coded, but as a secondary diagnosis. When the documentation says HIV positive or HIV test positive, and there are no symptoms, we assign Z21. The key is the absence of any HIV-related illness. This is one of the most important rules in HIV coding. Once a patient has ever been diagnosed with an HIV-related illness, meaning they've been coded with B20, they stay B20 forever. No going back. No downgrading. Never assign Z21 or R75 to someone who has previously met criteria for B20. If the record shows inconclusive HIV serology, we use R75, but only if the patient has never had a confirmed HIV-related illness. The one-way street rule still applies. When the patient is pregnant, Chapter 15 takes priority. If she has HIV disease, O98.7 first, then B20 plus any related conditions. If she's asymptomatic, O98.7 first, then Z21. For screening with no symptoms, we use Z11.4. If the patient has symptoms and is being tested, we code the symptoms, not the screening code. If counseling is provided, we can add Z71.7. If the patient returns for results and the test is negative, we use Z71.7. If the test is positive, we go right back to our main decision tree: symptomatic or asymptomatic. Medication alone doesn't determine the code. A patient with HIV disease on meds equals B20. An asymptomatic patient on meds equals Z21. We can also add Z79.899 for long-term drug therapy. For PrEP visits, we assign Z29.81, and we can add codes for any documented risk factors. This algorithm ties everything together. 1. Confirm the diagnosis. 2. Determine clinical status, B20 or Z21. 3. Identify the reason for the encounter to determine sequencing. 4. Apply special rules like pregnancy or the one-way street rule. The heart of HIV coding is simple. Confirm the diagnosis, determine the patient's status, sequence based on the reason for the encounter, and always apply the special rules. Once you understand the logic, HIV coding becomes very straightforward. Thanks for watching, and I'll see you in the next video.